very warm good evening to everyone who have
Ma'am,
joined us online
yeah, ma'am,
for
please.
this ORDI Rare Info series. So we have a very eminent person, Dr. Snehal Mallakmir, who is a very senior clinical geneticist. She's been practicing in Mumbai at a clinic of genetic medicine. She is a scientific advisor to MedGenome Laboratories, and she has lot of experience in handling a prenatal, preconceptional, pediatric, adult, and cancer genetic cases. She has been an invited speaker in many forums, and she also actively does lot of research, and she conducts lot of awareness programs herself to convey to public about the genetic diseases. So I'm very happy to introduce Dr. Snehal. Over to you, Dr. Snehal.
Thank you, Indhumathi, for the brief, and nice to see you after a long time. Thank you, Chetna and Audi, for inviting me for this webinar. And the topic, actually, the title which I had submitted to ORDI, role of NGOs in awareness about pregnancy management and genetic testing, ethics in the era of precision. And Indhumathi, and if there are other geneticists in the audience, they would definitely agree with me that there has been lot of at a very rapid pace happening in genomics. Along with that, whether we have been able to catch up with the developments in the management and along, especially ethics and morality sciences in view of the confusions happening after genetic testing. So there is lot of things are happening, and it is very difficult for doctors or as well as paramedical, paraclinical specialists present in the hospital setup to handle all these things. We definitely need NGOs, community spaces, all of them to help us in this management. Unless we are aware about what is happening in genomics, it would be difficult that at the pace which we are addressing Indian population, at the pace which most of the specialties in medicine are getting covered by genomics, it is very huge, and hence we need trained population, trained genetic counselor, geneticist, and not only genetics but various medical specialties trained in this especially genetic language of communication. And here role of NGOs is very important. So I don't think we have to go much details of genomic science. But my topic today will revolve around just introduction of genomic medicine to people who are involved in women and child health care, because that is a very utmost concern area when we go to genomics to have a healthy baby. The people working in public health and especially associated special children, how to share this information and how doctors and hospitals can support efforts of NGOs uh, to initiate a dialogue as to how these awareness sessions can further increase in the areas of practical implementation and collaboration. Lot has been happening when we talk about policies, or we get about making guidelines for specialties, but whether we really be able to implement it practically on the ground. So as the saying goes well, but that there is a need to have an enlightened citizenry, people who are aware of nature of science, in genomics especially, who use the scientific approach in their decision making. What are the gaps we see in genomic science that medical education is yet to catch a lot? We are seeing that genomics is being included in curricula in high schools and colleges, but whether we have been able to really update our medical educational curriculum in undergraduate and postgraduate, especially practical trainings, case trainings, history taking, phenotype, very defined phenotype of a patient, exactly labeling those terminologies when it comes to symptom, signs, and disease. That is what we have to address in medical education. The facilities which are concentrated till to metro cities and tier one cities. Even if the sample pickup, the NGOs are rapidly expanding for the transport and treatment facilities, it is still very short. Expertise when it comes to genetic science. We have been able to reach a lot through telemedicine, telecommunication, the meetings like Zoom now happening, video consultations because of, especially after COVID. But still, we don't find that expertise clinically reaching on the ground when we actually assess patients in busy OPDs. Socioeconomic data when it comes to assessing and addressing testing and treatment needs, patient awareness, patient education, collaboration between different specialties, because genetic disorders are usually multidisciplinary teams. And apart from highly specialized hospitals or medical colleges, we don't see that collaboration between specialties, and patients keep running from facility to facilities. Even after the diagnosis, they keep taking many opinions, and they might be, short of the specialties which have that expertise. We still have perceived barriers. They may not be real barriers. In view of explosion of information, everything is available on our mobiles. We still have perceived barriers, which include lack of knowledge, confidence whether this is a genetic case or non-genetic case, access to timely formal and informal consultation with that particular specialist, clearly defined role of NGOs and various specialties, and how NGOs and specialists can collaborate at especially which areas. When it comes to perinatal health or maternal and fetal health or mother and child care, there is micro environment and macro environment largely which we should be able to address. We should be able to address. When I'm saying macro and micro environment, I'm saying public. Private health space, right from family to move it on to community and to a national landscape. So we have role of family and family members, and implications of ill health of mother child for the family, understanding the burden of these diseases and their chronic nature, which really debilitates the families, financial, emotional, social health, whether we can build those facilities in their community right from societal support, whether we can find the areas of care which can be made better when we allocate funds, especially immediate care for bettering quality of life, adjusting school environment to the needs of people with genetic disorders, and collective efforts to make it affordable and widely available, and whether we can really start collecting this data, analyze it for betterment of public health policies. So right from the family nucleus, we have to that micro environment, we have to move it to macro environment for perinatal health care if we have to catch up with whatever advances happening in genetic medicine. This is a paper published by through an efforts of medical specialties and NGOs. We already, before we move on to genetics, we know that pregnancy represents a remarkable physiological journey characterized by hormonal, metabolic, immunological adaptations to support fetal development. So before we move on to genetics, we have a lot of other health conditions which have burdened our mothers. We have hypertension, we have gestational diabetes, thyroid dysfunction, we have nutritional problems, and diseases in the mother themselves. So they already have a profound burden on maternal and fetal outcomes. So we have to also catch up with early onset diabetes nowadays, obesities. And further to that, we have to address these genetic disorders in the fetus. I would like to touch upon this problem of adolescent pregnancies in India, even if this is not being addressed in this recent paper in an undergraduate journal, where in 2017 we have our National Family Health Survey cited that there were more than 10 million, 11.8 million adolescent pregnancies in India. So see the huge problem. We are struggling to have healthy mothers. We are struggling to have maternal deliveries, mother deliveries at better care and better hospital care within the hospital care. And we further are to struggling to adolescent pregnancies, which would clog nutritional along with all these problems. So this is also needs to be taken care of when we talk about maternal health and maternal fetal health. Generally, these investigations are being done in pregnancies, blood investigations for physical fitness, hemoglobin, blood sugar, thyroid profile is being done. Infection screening, thrombophilia profiling, bad obstetric histories or high risk pregnancies, blood test for chronic disorders. These are being done in specialty care. Many of the medical colleges may be, but I'm not sure, even in cities, whether we are addressing our high risk pregnancies with this general screening profile and offering whether it is being offered to all the mothers. Definitely not. And we don't have this data as to how many pregnancies are happening outside this, whether how many pregnancies are lacking this support. And once we have the general investigation profile during pregnancy, we have specific genetic profile like thrombophilia disorders being screened for bad obstetric histories, screening of abnormal fetus. We don't have still the facilities with expertise on fetal anomalies. Fetal medicine specialists are not available at many centers. We aren't having the consensus on guidelines of implementation first trimester biochemistry fetal scans at government hospitals, second trimester biochemistry like AFP, and anomaly scans at all government hospitals, including peripheral hospitals, rural hospitals. We don't have uniform guidelines for NIPS, whether we have to apply it in high risk pregnancies, whether we can offer it to all general pregnancies. We are having specific genetic tests right till fetal exome, but at one end. But at other end, we still are missing even genetic testing, invasive testing at peripheral centers where we are having gross abnormalities. We're terminating gross abnormal fetus, but we aren't following them with genetic testing on those products of conception. Carrier testing is available for common mutations for couples because because there are lack of facilities of investigating on a diagnosis of a child who has suppose a newborn death and query cause, or previous child has died who was being suspected to have genetic disease or unknown disease. So and the testing has not been carried. Then depending on the situation we have or the probable diagnosis, we have carrier testing in father and mother. In spite of all this profile available, this is not being offered at peripheral centers, and I'm sure that we have a lot of scope to improve. So much is happening in genomics at rapid space. We have prenatal screening, prenatal diagnosis, we have diagnosis available for disorders of reproductive system, male and female infertility, pregnancy loss, pre-implantation genetic diagnosis, pre-eclampsia, carrier screening, oncology, especially oncology when a mother is, having a precious pregnancy, or how to deal with mothers who have been facing at the same time some oncology issues and managing pregnancies, then premature ovarian failure. We have so many tests coming up. We have so much of precision medicine guidelines coming up in all these areas, and we have to also catch up at rapid pace with these genomic development. Uh, as for our statistics of sample registration system, more than 5% of birth defects they contribute to national neonatal mortality and under 5 mortality more than 5.7%. We have all these listed birth defects in our data. We have congenital heart defects, we have Down syndrome, we have cleft lip palate, we have multisystemic defects, neural tube defects, as well as we have developmental disabilities, we have vision and hearing impairments, autism, language delays, behavioral disorders. So, how many of these disorders are genetic? What percentage from this is genetic? What is non-genetic? We really don't have this specific data. We have been making birth defect registries. The labeled birth defect registries are there to be submitted at corporation hospitals or government medical colleges or government state hospitals. But we don't have segregation of these birth defects as to which have been confirmed which have been having the confirmed diagnosis, of those which are genetic, which are non-genetic, and that is what we are lacking, and we need to have major pilot projects regarding this. Just addressing few concepts in genomics, if we have medical students today here, that we are made up of cells, and we have been visiting this in our text and right from second year medicine. But if we have some community workers here today, they also should go through such figures and make those concepts understand, because they have to be in communication with patients and community. That we are made up of cells, we have inside the nucleus, we have chromosomes which are made up of DNA, and parts of these are genes. DNA makes up mRNA, which makes up proteins, and that's it. That is what, when the defect of DNA is there, protein is defective, and that is why diseases are there. So, such a simple language of communication has to be there in local languages when NGOs are going to meet patients, local organizations, local health facilities. We don't have even health facilities and doctors, primary healthcare doctors, ANMs, ASHA workers trained in these terminologies. They don't know exactly what is chromosome, what is DNA, what is gene, what exactly is meant by when we call it as protein is defective, when we call a word as mutation. So that is they are not able to explain it to the patient in local languages, which is very important. So we know that Down syndrome is trisomy 21, and we have certain chromosomal disorders apart from Down syndrome. And for that, we can have this karyotype, which is shown in this figure, and that is a diagnostic method. And we have, apart from chromosomal disorders like trisomy 21, 321 chromosomes, we have various other structural arrangements in the chromosome which can be detected with other investigations like MLPA, like microarrays, like specific fish test. And we have this DNA molecule where you have replacement or change in this nucleotides, where we have, which is called as mutation, and which can be detected by sequencing. Now most of us are moving towards next generation sequencing, like whole exome sequencing, whole genome sequencing, and these are the methodologies where we can address DNA changes. Now, when we come to explanation of reports, especially where we need help of NGOs to discuss out the reports to patients and family members. In the busy OPD, it becomes very difficult for pediatricians, obstetricians. But even in spite of giving 1 hour, more than 1 hour to patients while we counsel the reports, it sometimes they have questions. The families, family members, and community people have questions on those report terminologies, like what is gene, what is exon, what is intron, how the protein is defective. We keep figures in our clinics to explain it to parents when we go for pre-test and post-test counseling. But that is very important for NGOs to have their own material when they discuss these terminologies to patients. What exactly is DNA mutation? For example, when hemoglobin gets deformed and sickle cell is formed. So if there are figures like this which explain what is normal, what is sickle cell, what is how the RNA changes, how the protein changes, and how the structure of the RBC changes. Similarly, what happens in myopathies, musculopathies, or neurology disorders. So that is how the simple figures can explain a lot to patients, and the specific terms need to be explained so that meaning is conveyed to patients. We see so many multiple birth defects where not a single term can explain the genetic disease. Limb defects is a very gross term. Neural tube defects is a very gross term. Heart defects is a very gross term, which is usually patients can easily understand. But then you have to take them down and segregate and dissect the terminology that what exactly the baby is having the defect. Whether this is isolated cleft lip palate. Isolated cleft lip palate is having less genetic risk than the cleft lip palate associated with other birth defects. Isolated congenital heart disease, which is just a ventricular septal defect, is repairable if it is not associated with major genetic disease. So the pregnancy need not be terminated. But if there is a congenital heart disease, you need to first confirm whether there is any associated genetic disease, which can be severe. to prognosticate the disease. If there are birth defects which can be easily repaired, like orthopedic defects, then they may not be associated with major genetic abnormalities. While you have to also keep in mind that there are a lot of internal organ defects like kidney, gastrointestinal system, which may not be seen in sonography or which may not be easily apparent immediately after birth, and they may be seen after investigations. We have a huge burden of genetic disorders if we consider all the genetic disorders because of high birth rate in India. 500,000 infants with malformations a year. We have Down syndrome, even if it is said that 1,000, in some cases we get 1 per 800 to 900. We have beta thalassemia still to be addressed. We have sickle cell disease, and there are a lot of disorders like metabolic, musculoskeletal, mental retardation syndromes, the neurological disorders, and various orthopedic like skeletal dysplasias. So applications of genetics are wider, right from premarital genetic counseling, preconceptional genetic counseling. We have whole list of areas which come under genetic counseling and diagnosis. Like we have chromosomal syndromes, we have dysmorphology, birth defects, specific genetic disorders, ambiguous genitalia, and cancer genetics. So when we address these areas, this list of disorders can be circulated by those NGOs as a profile when they screen those disorders in a population. For example, if they target a project or take up a pilot project, they can circulate such applications to those kind of physicians or hospitals where they can easily pick up these disorders. Now, measuring the severity and application for treatments, like for this, precise diagnosis of genetic disorder is very important. But apart from easily diagnosable conditions, genetic testing needs very careful applications. Pre-test counseling is very important. Post-test counseling, whether this report indicates the disease would be severe. For example, sickle thal anemia it can present as mild, it can present as severe. So only detecting the DNA mutation or genetic mutation doesn't mean in itself that it is a severe disorder. Sometimes the disease presentation can be mild, can be late, may not impact the mental status of the child in spite of being associated with syndromes. The child can do very well. So presence of genetic mutation itself cannot decide anything. You have to measure the severity and then apply your treatments after the diagnosis in that particular case. And that is why correct diagnosis, I'm not saying correct only genetic diagnosis, correct genetic as well as clinical diagnosis is the 3/4 of the remedy, because as said by Mahatma Gandhi, because it really gives confidence to parents, confidence to the clinician who is managing the child, that what exactly I'm going to monitor in this child further, what is going to pose threat to patient, where are the expenses, the parents can decide where can they invest their physical efforts, where can they invest their financial efforts when they manage the child. These are general pedigree drawings which we have to be. I think many of the genetic counselors and geneticists keep it at handy, but I'm not sure that even NGOs who are dealing with genetic disorders, they have these handy pedigree drawings to be given to their community workers or not. Maybe they will be able to tell us more on this, that how can we make this training of drawing of pedigrees, which we have apps now available, which can make pedigree drawings. So and then that can be stored and sent to given to patients or sent to their doctors. Uh, for example, family history taking and deciding the inheritance pattern, so that the simple inheritance pattern, and you can tell that your report says autosomal recessive and the 25% risk of recurrence. So simple acts can also help to the primary healthcare workers, and they also minimize the work of the referring physician. Prenatal preconceptional genetic counseling, when it comes to when we meet a high risk family, or even if we are dealing with normal people, because every family deserves a healthy baby, every couple wants a healthy baby. So dual marker test and thalassemia screening of the mother, and good anomaly scan. So these are the very primary things which we have to build up resources even in government hospitals, and NGOs also should be pushing for this, that these minimal things, at least in India, we need to update. NIPTs can be reserved, especially in Indian setup, for high-risk pregnancies or high-risk families. But because the costs are down, case-to-case basis, we are seeing that even sometimes unaffordable couple are ready to take up NIPT when they balance out whether they have to go for NIPT or foreign villus biopsy or other testings like invasive testing when it comes to high-risk baby or high-risk pregnancy. So NIPT should be discussed with the patients, and it is their choice. We cannot decide from patient choice whether they are affording or not. Sometimes when there are multiple abortions, when they have to balance out their options for precious pregnancy, they can take up any diagnostic or screening options as suits their needs. Then we have newborn screening. Newborn screening, we have different panels. We all know that we have only congenital hypothyroidism CH panels. We have other rare disease panels. We have all metabolic diseases screening panels. Nowadays, we have lysosomal storage disorders on request if we have previous child diagnosed. So we have a lot of things which can be implemented. And since long it is being discussed, newborn screening, I remember I was a part of newborn screening program, pilot program by ICMR when I was doing my fellowship. And still we haven't been able to conquer major areas apart from private practice or corporate practice. We still are behind in applying newborn screening at a wider scale, and that has to be considered in joining our policy decision making when we talk with NGOs and taking them together for how we can do this better. This is just a case where you see a couple. This mother approached 24 years, and we have first MTP done for fetal anomalies, and second is the current pregnancy at 12 weeks she has come. Now she has two brothers with Wilson disease. One brother died of disease, another brother is still on treatment. Now, here are multiple problems in the family. It is so difficult when they go from doctor to doctor whether those fetal anomalies are related to Wilson disease. No. So, further, first pregnancy was unrelated to Wilson disease. There are four family members of Wilson disease in the family. She could be carrier. And nowadays, Hepatology Gastroenterology Society says that Wilson disease has treatment, so prenatal diagnosis may not be mandatory, and it takes. This family rejected Wilson disease diagnosis or carrier testing. They wanted to test only for severe fetal anomalies in view of their first pregnancy. So there are a lot of things in only one family that we have to test affected family member, whether they are really confirmed Wilson disease patients and which gene mutation. Testing of carrier state of pregnant mother, whether she wants to do that pregnancy testing. NIPT, whether it needs to be offered or directly any invasive testing if the anomalies comes abnormal, and how we are going to follow up this newborn in view of this precious pregnancy. They have lost one baby and they have affected members in the family. So there are a lot of pregnancy genetic dual marker also, NIPT also, prenatal also from doctor.
Dr. Snehal, I'm sorry, we are not able to view your slides.
Indhumathi, am I audible now?
Yes, yes, you are very much.
Yeah, this case I was discussing right from here. Yeah.
Yeah.
Oh, I'm so sorry. So, yeah, so I was discussing this case where there were multiple problems in this case, multiple genetic test options, carrier options. So, just to not going into the details of a case, but people would, definitely agree, and they would resonate with me that every high risk pregnancy, especially complicated with genetic disorders or genetic history in the background in the family, needs multiple counseling sessions, help to family members, help to affected family members. They may be having financial burdens going on to different genetic testing. And here, we really definitely need some of the community support to these patients, not only for expenses, but understanding the importance of precious pregnancy. Now, come to therapies. We ORDI has to be credited when and many NGOs in India for bringing many therapies to India of especially rare disorders. We have many therapies available which are really expensive, but rare disease policy also has made easier for many patients. And some of the therapies which I have shown are under research now. So understanding research of stem cell therapy, gene editing, TCAR is also important unless there is involvement of NGOs for spreading the knowledge, especially when we are dealing with ethical issues, which is the main concern of for today's topic. That right from labeling any person with different appearance is not purely should be correlated with the disease when we are dealing with normal people, like height, color, gender. Somebody labeling a short stature that this is genetic short stature, family hai aisi hai, ya color or gender, tabooing the genetic disease on that person, family, or specific population which carries that high risk gene. Genetic disease may not be always hereditary, they may be de novo sporadic. So, this communication and awareness and knowledge should be spread right from school days, and that is what will make community support very easier for NGOs and doctors. Unless we keep communicating through schools and colleges about this, which I've been part of one of the trainings, then genetic reports have to be done in accredited laboratories, because we are seeing many variants detected in the patients who are incompletely worked out. We have to repeatedly then work them out, finalize the genetic reports. So whether we are really following standard guidelines for reporting, the interpretation of those reports is very important. I'm sure many NGOs have started coming across these problems, and they would agree that we really need to sit down and how we are going to address these ethical issues in local languages in all the communities in India, seeing heterogeneous population of our country. And we really have to be sometimes very simple and basic when we are also addressing our genetic terms. At one end, we are having gene editing, its research, stem cell research. So whether any disease is still in research in India, most of the patients coming to us that we have read that this therapy is available, this research is going on somewhere, and we want to be part of this. Whether this is really scientifically going on, unscientific stem cell treatment. So that information should be avoided, unscientific, and should be conveyed what is the correct information. Possibility of insertion of toxin producing, unethical gene editing experiments, community awareness should be there, vigilance policy wide should be there, and there should be strict, careful monitoring and validation of scientific research as well as auditing of such research. Participation in such studies by human volunteers needs community awareness about consent and ethical guidelines, because genetic disease patients and families are already burdened. They are looking for treatments. They will run away for any treatment. We are seeing stem cell treatment in unauthorized stem cell treatments in many of the genetic disorders, and they really catch up. Whoever offers the treatment, they feel that there is a hope, but they have to be strictly monitored, audited, validated before we start talking. And that information also should reach out. We have so much of media platforms nowadays, but we need to organize that messaging to the community through primary health care workers, through NGOs, through ASHA workers. And this is bioethics, biosafety, biopiracy have to be. I mean, when we have exploitation of living organisms for human interest, use of biological material, especially in the world of copy paste, how do you organize this material, and conveying the exact scientific meaning is very important. So how do we look at NGO partnerships when it comes to pregnancy management and genetic disorders? We know that health is a state subject. Decentralization is priority under our national health programs. So every state may have their priority areas for partnerships of NGOs according to the budget allocation, according to the that disease which is important in that state. And different NGOs have different range of capabilities and areas of expertise. And hence, the NGO involvement has to be prioritized as per state also, but also with ongoing our needs of precision medicine. So NGOs could be effectively involved in training, service delivery, supportive supervision, monitoring or advocacy research innovations in maternal child health, including right from especially our genetic patients, sometimes high risk, they need immunization like pneumococcal vaccine, sometimes high-end vaccines. So people or patients or families who are not affording, but many muscular disorders or respiratory disorders, immunodeficiency patients, they need such immunization, even if they are not recommended sometimes in normal children or not available in government hospital for normal children. These special disease patients need those immunizations. So what can be done to regularize that immunization and newborn care? Sexual and reproductive health in patients who are having learning disabilities, especially where they repeatedly need assistant care, adolescent health, including school health, malnutrition because they are neglected patients, communicable and non-communicable diseases in growing adolescents with genetic disorders, genetic disease screening of family members, and because genetics is always integrated into PNDT at healthcare setups, so how it can be associated with monitoring of declining sex ratio and intersectoral convergence. We should be having supplementing capacities. For example, in some areas where they have interest and high priority, but medical professionals are unable to give continued attention because of high burden of general disorders. We should concentrate our NGO capabilities and coordinate and collaborate with them for high-risk genetic screening, rehabilitation of these patients, counseling support system, monitoring of PSP and implementation integrated with genetic disorders, prevention and family member counseling. And this would also support, and we can find people from population and professionals volunteering for such support. Support for unserved and undeserved areas, for rural very units, for mobile medical units where we can collaborate in those areas, or inaccessible and hard to reach areas, especially because in those areas patients are also difficult. Our patients are sometimes genetic patients are chronically debilitated. It is difficult for them to come from those areas and go to specialized center. So in such areas also that rehabilitation care or management of secondary disorders care or morbidities is very important. And with the use of telemedicine services have that strength of providing at least primary information of genetic disorders for patients residing not only cities, even in cities sometimes the reduction of the pricing and the traveling distance makes a lot, comfort for families who have to carry those patients to repeatedly to doctors. Carrying a disabled child by the mother to the doctor itself a whole day's task for that mother or the family. So sometimes telemedicine is providing a lot of relief to those patients and reduces travel and work cost. There have been reports of success stories in India of reduced infant mortality by using telemedicine, improvement of immunization, safer maternal health practices, better diabetic control, higher diagnosis of, for example, diabetic retinopathy. So we can come up with, especially ORDI can come up with some of the pilot projects and data analysis and submit it to it, that in which areas in genetic medicine we can help by telemedicine, and which are the gaps which can be addressed by addressing sample transport, remote diagnostic facilities for at least general disorders, even if not very specialized areas of genetic medicine. And gaps are also still not addressed, like ethical guidelines, security, data security, especially getting photographs of patients and families and video recording. So competence and quality of that NGO and but people from healthcare and doctors who are doing the telemedicine is needed before we apply this. Whether we can also integrate school policies in NGO care, that how the schools are addressing their academic and behavioral problems in these children, attempt to understand the nature of the disease in the child, whether there are any at least primary support facilities at school. I've seen some schools who have who have already integrated special ability children. The fellow students, they understand, they allow mothers to help for the curriculum or for writing or reading to those along with those students. And at some schools it becomes very difficult by school to teacher ratio, and as well as facilities. So parent to school communications can be bettered. Participation of schools in our awareness programs along with NGOs who are working with genetic disorders, and how we can address financial burden to these families, educational burden, supporting education for these children, as well as managing their disorder. So they have the exponential financial burden in these children. So whether they can serve some support in education, we can provide to these families and children. So we have to bridge those gaps, need to understand our own data of patients, about incidence and prevalence of disease, right from mild, moderate, and severe. How can we concentrate our facilities where we have to address severe genetic patients, whether we can lessen burden in some of the areas of mild genetic burden, genetic disorders, how to build resources depending on our social circumstances and needs, depending on our facilities, where we don't have the facilities and where the facilities are too much concentrated on apex centers or highly specialized centers, whether we can receive that feedback, even feedback from various specialists, feedback from NGOs to doctors, doctors to NGOs, and coming together of patient parent groups, which the organizations like ORGI are doing excellent. Like they are having programs or support groups, parent groups, funding resources. But I'm not sure whether this NGO network has grown beyond few organizations in genetic disorders. We need to catch up a lot. So we have to really join our hands together for prevention in pregnancy, newborn, family support, and community. A lot needs to be done for treatment and rehabilitation. I'm not saying only targeted genetic disease treatments, but for example, treatments of morbidities, as simple as that some of the patients with mild learning disabilities, autism, or developmental delays, they sometimes have sleep disorders, which increases their behavioral problems. They may have sometimes apneas, they may have repeated allergies which go unaddressed. They may have issues in visual, refractive errors which are not being taken care of. Simple problems can increase their behavioral disorders. So we on one have the disease and we have comorbidities which increases the severity of the disease. And that happens in almost all the genetic disorders. The secondary and tertiary aspects of genetic disease management and treatments can be taken care of. Even we are saying that genetic diagnosis is expensive, genetic treatments are expensive. Whether we can really look at least addressing at primary health care facilities, treatments for comorbidities, treatments for the disorders as simple as pneumonias in these children, whether they are receiving immunization, whether rehabilitation facilities are can be coordinated with the primary healthcare center by increasing community support and awareness. And this will only be achieved by good research, good data analytics. There are many people coming up with softwares where like we have our precision medicine and genetic diagnosis softwares, we have many startups, we have many software companies where they have softwares which can treat ASHA workers or assistants at NGOs, and they can fill up the community data, and that is easily doable. The once the data is digitized, that can be shared across professionals, doctors as well as non-clinical professionals, and this data analysis then will help us organize the care where needed. So we are not only moving for diagnosis regarding precision medicine and treatment. We have to move on to this precision as to how we, distribute our resources, and how, depending on this research analysis, how we can precisely refine our public health policies. And I think here NGOs can contribute and collaborate a lot, because they are easily approachable. They mingle with community healthcare workers and families alike. So, in a better way, they can also train those, help training those softwares where they can use simple language. Sometimes they can make local language inputs, which can be then analyzed in a precise scientific language. So, I think joining hands together, along with when we come to genetic disease management, is very important in public strata and NGO. I hope this presentation has summarized how we can easily find areas where we can work together with NGOs. Thank you, Chetna.
Thank you, Dr. Snehal. You have shared your vast experience in genetics and the way you reach out to the community to help out patients and families. This is very, very useful. If there are any questions, the participants can post in the Q&A.
I think one person has posted most NGOs and parent support groups are made up of affected families themselves, meaning they are not medical professionals. This can limit the amount of support they can provide. So, how can they cope up with these challenges? And some doctors feel uncomfortable engaging with NGOs alongside families. So, how can we make easier for them, given that doctors are essential for treating patients? Absolutely, yes. And especially genetic disorders, most of the NGOs' work energy is driven by parents themselves. uh, I agree that we have to take and find volunteers apart from parents in these NGOs. How to cope up with these challenges? We have to start getting engaged with, first, with medical organizations like Indian Medical Organization, which is made up of general practitioners. So not only allopathy, we have to take IMA, we have to take similar Ayurvedic and other facilities where these families go for management, and sometimes they may be missed or delayed diagnosis. So unless we take them to awareness, and then we can move on to specialties like subspecialties, pediatrics, and other things. Then we have to also take into consideration various mental health facilities. So we have various arms. Here we have to take them into genetic training and awareness sessions, which I had mentioned in my last slide. And second question, that yes, some doctors feel uncomfortable engaging with NGOs alongside families. So I'm not sure how to express this, because whether it is really doctors feel uncomfortable, or whether they can't give really time, special time to engage with the NGOs, that has to be created. I think that needs a creation of special space in public health. Like, for example, you have many corporation hospitals. We have Navi Mumbai Municipal Corporation Hospital. We have very well equipped corporation hospitals and medical students in it, in corporation hospitals and civil hospitals and district hospitals, state hospitals. So, if we can create some collaboration with NGOs, like, for example, ORDI or their teams, and we have at least put one desk of genetic counseling once in a week or once in 15 days, then I think we can start taking together these families to, along with doctors and to local facilities, and similarly in private spaces. So I think various organizations, such kind of, we have on one side, we are having, Indhumathi would agree that we have training sessions for doctors to diagnose medical conditions, to how to treat those conditions. But at the same time, we have to take doctors' organizations and paraclinical organizations for training in this public health space, right, Indhumathi? So this training and this dialogue of public health should increase in conferences and such meetings.
Dr. Snehal, I remember you had some training for ASHA workers regarding
Yeah, so
genetics. So, how
yes,
it had
so
really helped to actually
So
diagnose
we,
and
I
test.
recently, yeah, I recently had one pilot project with, I'm in Maharashtra, so Marathi Vigyan Parishad, which is a scientific organization working with schools and colleges for, training in local languages and science projects. So I had partnered with them, and we had a training for more than 1,000 people from school and colleges, where I had the genomic project module. And the response was encouraging, that students are also learning that in textbooks, but they wanted practical application, that what exactly genetic disorders are, what do you mean by tabooing, what ethics need to be followed, what exactly the genetic testing and reports are, and how the genetics apart from medical genetics is being used, like GMO plants, then recently heard gene editing, and then plants and agriculture. So a lot of enthusiasm is there in community. I think we are falling short to address this, and we have to take our experts to these community groups also, which may not be medical, but through non-medical groups also and organizations also, we should start collaborating so that we can give our message well. And with this only the community support will grow, because we have more aware citizens, which I used in my first slide, that we have more aware citizens of this problem. They start creating that compassionate family in the society, and then the community support starts building up.
Dr. Snehal, I think we have some policies for registering NGOs and things like that. So I feel that the government has to mandate the association of for a doctor or for a genetic counselor, depending on the type of the medical situations that they are going to deal. They can recommend or on board of expertise like
Exactly. So
yeah.
that is why we like Indhumathi, we are having conferences, discussion of diagnosis and management. No, we also should be having this public health policy integration, right?
Yeah,
Of
yeah,
experts. And here we have health experts, paraclinical. We have so much from diagnostic field, no? We have so much
yes,
of laboratory expertise and genetic counselors and NGOs, which can come together and form such groups which can help states at their levels or district facilities.
yes, yes. So definitely the telemedicine, the one of the discoveries of COVID is really helping the tribal, the remote access is been becoming very fantastic. But I also feel there are limitations in reaching out in local language, and there is lot of lack of people with knowledge in genetics. I think that is also one request to the forum, that there is lot of opportunities here in genetics, and looking forward for more people to coming to this area.
Yeah, yes. And definitely ORDI like institutions which have grown it up. I mean, they have grown by parents only. So they can also seed how small such organization can build up at local level by, by different leaders, not from parents and other health facilities. Like you have mental health facility, you have people working in women care, they can be taken together and collaborative sessions for training them in genetic terminologies, at least primary training.
Yeah. So, if there are no questions, thank you so much, Dr. Snehal. See, like
Indhumathi.
NGOs, we used to as we had a question. Most of them are by the parents for the affected individuals. It has gone up to creating awareness, reducing stigma, improving access, and getting actually the rights for the patients. But now it has become much bigger, that the testing is available, the facility is available. It has to be more appropriately guided, utilized, and of course the ethics, the privacy, the confidentiality has to be very well kept in mind. So this all becomes possible only when we jointly work, the NGOs, clinicians, researchers, policymakers, patients, and all of us. And thank you for bringing this out. Thank you so much for your
Thank you.
time.
Thank you. Thank you,
Thank you,
Chetna.
ORDI, for the opportunity too.